Tell me when we are ready to go.
I think, can you see that? Did you see that we're recording message?
I can see that.
Okay. All right. Then good. All right. Well, welcome everyone. I appreciate everybody's attendance today for this quarterly training. We'll get started here in a second. Just a couple of housekeeping things. One, we are still trying to work with Post on whether or not we can get Post credit for this particular hour. So I encourage you all to sign a roster and send it my way afterwards. Ada County Sheriff's Office is kind enough to enter these for us in their system, but I prefer to send them all of the rosters at one time. So if you'll all just send them to me, I'll hold on to them until we have everyone's, or I think we have everyone's, and then send them over to the Sheriff's Office at the end. So I appreciate that. We are going to be tight on time to get through the entire presentation today. So I think we're going to ask that if you have questions, if you would put them in the chat, we think that would be the best way to handle that. And I will call them out for Kate, our presenter here, as they come up. So we'll try to keep on moving through and keep a decent flow on time. I think that is all. We are recording this. Of course, if you watch the recording later, you definitely can't get the Post credits. That's a Post thing. So for everyone here, we're going to try our best to get that approved. And then we will have this available for you or for your teams or people who missed it, if they're interested, on the Association of Counties website once we have the recording finalized. So it'll be available later if anybody needs to go back and look at it again. All that being said, again, welcome and thank you. I'm just going to hand it over to our presenter today is Kate Pape. She's with the VA and she works in the suicide prevention area at the VA, but she has tons of other experience and other specifically experience with law enforcement organizations, which I'm sure she'll tell you about. And definitely a lot of experience in the area of suicide prevention. So I'm just going to let her introduce herself to you all and take it from here.
Thank you, Sandy. Can everyone hear me okay? Thumbs up. Awesome. As Sandy mentioned, my name is Kate. I'm the current program coordinator for the suicide prevention program at the Boise VA. Even though it's the Boise VA Medical Center, our catchment area extends through a wide swath of Idaho, up to Eastern Oregon, as a matter of fact, up to Salmon, up to Idaho Falls, where then Salt Lake City VA takes over that geographical area. So Boise VA, but large part of the state. Really happy to be here today for this training. Before I start with specifics on the training, like Sandy said, just a little bit about myself so you know who's providing this training and who is sharing the information today. I am a licensed clinical social worker, got my master's degree back in 1998, and have done the majority of my practical career working in county jails. In fact, most of my really comprehensive training was in the Los Angeles County Jail back in 2000, from 1998 to 2004. And I worked in the Ada County Jail for 17 years. Last 13 years when I worked in the Ada County Jail, I was our healthcare administrator there, and I was part of our command staff team for the Sheriff's Office. And I was honored to be able to go through the Northwestern School of Police Staff and Command in 2020. So I come to you with really just a lot of kind of that healthcare within a law enforcement setting training and a lot of suicide prevention background, because everything I've done in my career has had that piece of suicide prevention in it. On this first slide, I list people from our team who might show up in this training. Our team truly does do suicide prevention all the time, and there's a lot of demands. So if they're available, they'll pop in. So I want you to know who might join us during this training. So before I start, because we are talking about suicide for an hour, I want to recognize that for some folks, this can be a difficult topic, right? Whether it is a personal experience with some kind of suicidal thoughts or actions or someone we love, or some kind of peripheral interaction with someone who's been suicidal or someone might have died by suicide, this topic can bring up a lot of feelings for folks. So just want to recognize that. And if you need to take a break and step away, I'm not offended. I can't speak for how that might affect post credit or attendance credit, but really your self-care takes priority and takes precedence. So want to make sure that you take care of yourself first. Also, we talk about the fact that that 988 Lifeline is a crisis line for everybody, not just for other people, not just for people we work with. So if it's something that can be helpful for you at any point, calling that 988 number is really such a great resource. I always say, especially when it's 3 a.m. and your mind's racing and it's not really reasonable to call someone else. If you happen to be a veteran, if you press 1 after calling 988, you'll get the Veterans Crisis Line. And in fact, my own team in Boise might be available to follow up. We tend to follow up with those Veteran Crisis Line calls after the fact. Really, the most basic hope for this training is that you have an increased awareness of someone who might be at risk of suicide, and then really have kind of an additional tool in your toolbox to know what to do when you identify a person at risk. My guess is for people on this call, there's a wide spectrum of experience and background and training. So our hope is, though, regardless of, if you have extensive training and experience or you're brand new at this training will help give you some really practical tools to be able to use to increase your sense of competency when you're dealing with someone who's suicidal. I have a coworker, Victoria Thompson, who's a social worker, and she does such a nice job of talking about the fact that when we're working with someone who's experiencing a suicidal crisis, we kind of adopt that crisis brain. And just like they might, we tend to then also adopt potentially that tunnel vision where we don't really think about the same options that we might if we're clear-headed. So this training, again, regardless of your background, is pretty straightforward and pretty clear. And so we hope you leave today with just, again, another couple tools for your tool belt so you feel a little more comfortable if you're concerned about the person you're working with. And so you have an idea of kind of steps to take and kind of what to do in the moment. As we mentioned at the beginning, I do work at the VA. But this training applies for everybody. So I want to make sure that everyone understands we're talking about the general population here. If I lapse into using the word veteran, forgive me, because we do tend to work with veterans at the VA. But again, this is widely applicable to everyone we work with. So before I start, we're not going to answer this question now, but I want you to think about what questions you might have about people who are in crisis or experiencing a suicidal crisis, because our hope is that even though this is only an hour training, at the end, that I have answered any question you might have come with today. And if we haven't, I hope to answer those questions at the end. Just check, everyone hearing me okay? Video's working okay? Sandy Jones, everything good? Awesome. And again, as Sandy said, please, you're welcome to also ask any questions during the training just by putting them into the chat, because we have a lot of content to go over, but we do want to get those questions answered as well if you have any. So really just one slide today with some data on it, but we really want to stress how much of a national public health problem suicide is. The last VA report was from 2023, so it shows data from 2021, but this is data for the general population, not just for veterans. In 2021, we know that there were 48,183 suicide deaths recorded, okay? And I'm going to come back to that in a second. We know that the rate for males was 4 times higher than that for females, and more than 50% of suicides were by firearm. Unfortunately, we also know that this number is probably vastly underreported. We know that coroners often don't report deaths as a suicide, oftentimes at the request of families. We know that a lot of coroners don't receive training in how to accurately reflect suicides on death certificates. And there's still a lot of stigma regarding suicide. So a lot of families will request that it's not identified as a suicide. We also know that simply just a lot of deaths that are completed by suicide just aren't documented as such. We also know that there's a lot of overdose deaths that fall into that gray area. We're not sure if it's intentional or not. So we talk about 48,000. We know that number is probably significantly higher. The other number on the screen that I believe is really significant is the number of people who are impacted when there's a suicide death. And if you've been impacted personally, again, even peripherally, like most of us have, you may not be surprised to hear that the number is about 135 folks are impacted when there's a suicide death. An example of this is, unfortunately, we had a really unfortunate contagion of youth suicide in Boise this year. every time someone dies, if we think about that ripple effect of everyone who's affected by that death, be it teachers, fellow students, friends of the family, relatives, and then everyone else, right? Other teachers who may not have met that kid. I know I was affected by hearing about that contagion of youth suicide. And so we know that that's very real. A recent example is we had a veteran die of suicide just a couple, maybe a month and a half ago, I guess. I heard today that there's folks out at the National Guard who are still struggling with that suicide because they either knew about that person or they were very familiar with the situation they're in, right? We're very compassionate people, and our heart goes out every time we hear about someone who dies of suicide, especially if their current context is kind of similar to our own. We also know that veterans die exponentially greater by suicide than the general population. Some of that theory happens to be that veterans are trained in the use of lethal means, in the use of firearms. And they're also taught to kind of be strong, not seek help, problem solve, take care of issues on their own, and not complain. So they're less likely to reach out for help. Provisional data at the bottom of that slide indicates that in 2022, the estimates were for that rate of suicide to only increase. We also know that suicide isn't something that's easily identifiable, right? So there's so many things that contribute to someone, if someone's going to die by suicide or not. I don't need to read the slides because that's boring for all of you, so I'll let you read that. But there's some suicide theorists that talk about suicide risk being a lack of coping skills and a lack of coping techniques. Other suicidologists talk about suicide being a complex mix of someone feeling like they don't belong, not having a connection, but then also people who are at risk of completing suicide also need to have kind of a lack of a fear of death, right? Most of us by nature try to survive, right? We do everything we can to survive. I go to the Y 3 days a week to help me be better and to help me cope with stuff, right? Our nature is to try to support us thriving. And so if someone really is at risk of suicide, they kind of lack that, right? That desire to stay alive. And so there's a lot of things that go in to someone really being suicidal. And for the most part, the assumptions we make maybe fake, right? Kind of coming back to you can't tell a book by its cover. We might assume someone might be at risk, but the reality is we don't really know everything that's going on in their lives. So we never really want to make that assumption. What we can do, though, is look at some concrete factors that might help tell us a story. I think that's a street cleaner outside my house. If you can hear that, I apologize. It'll pass in a second, I think. But because we really don't know why people kill themselves, which is a blunt word, but that's the reality of it, we look at factors that help us to, again, like I said, kind of create a story of what's going on with that person and help lead us into having an idea of what's going on with them. And typically, our team looks at risk factors and protective factors. Those factors that are going to be putting someone at an increased risk of suicidal behaviors, but then also those protective factors that can help really be a safety net for someone who's experiencing stressors. So we're going to start by looking at risk and protective factors. And what I want to do is look at these through a new lens, right? Because we make assumptions all the time. Whether we think we do or we don't, we do. Part of my background that I kind of kept out, it was just a short 2 years before when I worked at the sheriff's office in the VA. I worked at St. Luke's for 2 years in the ER and then a supervisory role in the hospital in the ER. And I'll admit, we had our own frequent flyers, right? Oh, and in the jails. Oh my goodness, right? Like we had biases all over the place. So we talk about them, but we know we had frequent flyers who would come to the ER because they're homeless, right? And they're looking for a warm place to stay and just trying to get out of the element. So we were always suspicious. Like, are you really suicidal? Are you just trying to come in, and get out of the rain or snow, which is understandable. Folks with substance use disorders, there's still so much stigma around folks who are experiencing substance use disorders. And what I really want to stress on this slide is, regardless of our own bias or the community stigma that exists, we want to recognize someone who does not have stable housing or someone that's dealing with a substance abuse risk are at increased risk of suicide. So as much as maybe they get under our skin, maybe they're complicated folks to us for us to serve them, we want to just, again, come back to the facts here and recognize that those are real risk factors. What we see so often is that relationship issues are a huge risk for folks. When we see relationships ending, whether it's a divorce, bad breakup, people tend to get that tunnel vision. Like I mentioned earlier, they don't recognize their coping skills that they might otherwise utilize to be able to cope with it. And it feels like everything's over for them. So those relationship issues tend to be something that we see as a really, really big risk factor. I'm curious, as I'm looking at this list, if anyone is comfortable coming off mute. I know we said we have a lot to cover, but I'm always curious about this piece. And if you're not, that's okay. But is anyone comfortable coming off mute or writing in the chat risk factors that you see most often with the folks that you all serve? Curious if you're seeing folks with mental health issues, substance use issues, housing issues, unemployment, but what are you seeing that seems most apparent with the folks you serve?
I would say housing. Very serious problem this time.
Do you have any resources for folks who are struggling with housing?
I mean, I'm in Idaho County, and there's a Idaho housing seems like they're moving through the people faster, but to jump through their hoops is a lot. And then I've had 2 people get through their hoops, and then they only give you a certain amount of time to find housing. So even if you have a voucher, it doesn't mean you're going to find a home or an apartment or anything. So that's what I saw. They got their Idaho housing voucher and couldn't find the home in the time frame that Idaho housing had available. So
yeah, I appreciate you sharing. And I think that piece is so hard. When we talk about meeting our foundational needs first, housing is one of the most foundational needs that we have, right? Is a roof over our head, is having a safe place to sleep, because the other piece that comes with having a home is safety. Safety from other people, safety from the elements. And I'm looking in the chat, right? Homeless with a pet. I've heard people, ask that question before. If you're homeless, how do you support a pet? Sometimes a pet is someone's biggest protective factor. Maybe that's their only family. And so it might be easy for us to suggest, if they don't have a place to live, they should give up their dog. Their dog might be their reason for living, right? It might be the biggest protective factor. And I also see financial stress and substance abuse on that list. Financial stress, especially with the cost of Boise housing, is so real. And I think we see it everywhere right now. It is so complicated to stay afloat financially in Idaho, even if people have reasonable jobs. It is a very complicated stressor, especially when someone is responsible for other people as well. So very clear risk factors, and I appreciate that input from what you see. So what I would suggest is we always want to take into account someone's risk factors, at the same time be really thoughtful about the protective factors they might have, and never make assumptions by either, right? So just because homelessness might be a risk factor, it doesn't necessarily mean they're suicidal. It just means they might be at increased risk. So we also at the same time want to look at the protective factors that those folks have. And again, not make assumptions, because social and emotional well-being is a great protective factor, and a sense of connectedness is a great protective factor. So if someone tells us they have a family and they're married and they've got kids, we don't want to assume that that's a protective factor. That family might be the biggest stressor that they have, right? So we always want to investigate a little more and ask those questions if those relationships are healthy, if they're positive, if the folks in their life provide them with support, because it may be the opposite. So we always want to check that out and make sure that we are digging a little deeper to really identify what those risk and protective factors really are. There's times when I've talked to people, whether actually usually in jails over the years, but in the ED also, when I almost can't find any protective factor. And my guess is you've all had folks that you work with who are in that same place where everything has kind of gone to hell in a handbasket for them, right? And I try to talk with them about what protective factors they might have, and they just don't see any. And it might be because of that crisis brain. It might be because of that tunnel vision. but they're not able to come up with any protective factors. That is when I tend to, because I don't always come to this first, but really inquire a bit about if they have a sense of spirituality. And it doesn't have to be a religion that I practice or that someone else practices. It's about a sense of spirituality that is unique to them. Because oftentimes that's a protective factor when they don't have any other tangible kind of protective factors. The other piece I talk about with folks, if I can't find any other protective factor, and there's times even in our team, we do suicide prevention all the time, when we feel like we are grasping at straws. So another thing I talk about with someone is if they're young, I point that out. They have their whole lives ahead of them, right? We don't know what's going to come next. And we talk about maybe different ebbs and flows in their life and things that came along that were a pleasant surprise. And so I do talk about, we don't know what's going to happen in the future with them. We just know right now we need to be able to resolve this crisis so that they can see what the future brings. So sometimes we really work at identifying protective factors for folks when they're unable to identify them for themselves. One of the risk factors that we talked about on the previous slide. Oh, sorry, really quick, squirrel moment. We have a lot of squirrel moments in the work we do. I do see that my coworker Victoria chimed in on the chat also. So she's talking about statistics for homelessness. So when you get a chance, go in and look at her data in the chat on homelessness. So as we saw on the previous screen, in terms of risk factors, we know that access to lethal means really increases someone's risk of suicide, especially if they have more risk factors, less protective factors, right? So this is, I would say, one of the primary things we're talking about with people these days. Even if they're denying suicide, we're talking with everyone about lethal means safety. So many people who live in Idaho have guns. Veterans especially happen to have guns that are unsecured, either on their person or in their home. So we are taking great steps to provide education to people across the board, because we know that if we can create time and space between thoughts of suicide and access to lethal means, we can decrease that potential for suicide by 31 to 40%. That's huge, right? And the VA does a great job at research. We are a huge beast. We are not a perfect system by far, but we do a really great job of doing research. I mean, not me personally, other people. But so when I look at these numbers, they're using the phrase, we just need to make it mildly inconvenient to access lethal means of suicide. So I would suggest for the people you're working with, at any point in your conversations with them, having a conversation about lethal means safety will help prevent suicide. We'll talk a little more about how we can do that and what that looks like. But here's a slide illustrating again that creating time and space is a really helpful tool to decreasing suicide. What we're looking at on this slide is that typically when someone's in a suicidal crisis, it doesn't last very long, right? Usually the crisis happens and it's resolved within an hour. As you can see, 71% of those crises are resolved within an hour, 24% of them within 5 minutes. So what we want to do is make sure someone doesn't have access to an unsecured gun in that time frame. Because if we do, we can save their life. Really impactful slide here and graphic that 85 to 90% of suicide attempts by firearm are lethal. That is huge, right? We know that all other methods combined, 95% of the time, someone's not going to kill themselves. But if they have access to a gun within that period of their crisis, the potential for a positive outcome is really low. So what I'd suggest is we want to be proactive and have these conversations with the people we work with before they get to that crisis, right? We want to make sure that before they have those suicidal thoughts or those thoughts of wanting to kill themselves, that their lethal means are already secured. Maybe it's in a gun safe. Maybe it's they keep their ammunition away from their gun. Maybe, especially if we're concerned about their safety, maybe their neighbors can hold on to their guns just for now, right? We want to make sure that everyone knows we're not trying to take away their guns. We're just trying to keep people safe. So we want to make sure we have those conversations and that we identify techniques to keep that lethal means safe. We also talk about keeping folks' environment safe. So gun safety is one of the biggest focuses because we know guns are used so often when people die by suicide. But at the same time, if we can reduce people's access to a ton of medication, that's something that can also reduce access to a lethal mean. So if someone's on a lot of medications, if we can get them a pill box, and then they literally just put their pills in their boxes for the week and then store their large bottles of medication somewhere else, we're making it a little inconvenient for them to access that lethal means. So again, whatever we can do to help support everyone on this call with reducing access to lethal means, we're happy to help. If you have a veteran who has guns that aren't secure, we can send out gun cable locks. We do it for free. It's part of our mission. So let us know. We can send out, oh gosh, hundreds of gun locks. So feel free to put your name in the chat. Let Sandy know. But we're happy to follow up afterwards and make sure people get anything we can to help decrease that space between time and action. I know I talk fast and I talk a lot, so I'm going to take a break and ask if there's any questions before I go on to this next section.
Nothing in the
Okay,
chat.
then I'm going to take the opportunity. Oh, what, Sandy?
I just said nothing in the chat.
Thank you. So I'll use the chance to take a sip of water and check the time. Okay, I'm going to go through common myths versus realities. And what I want to preface this with is some of these look almost silly. So I'm going to share my personal experience with them because we think, oh, we'd never think that. We absolutely do. I would challenge you to really think about scenarios where maybe you've shared some of the same thoughts I have. So these are just good reminders, right? That it is a myth that asking someone about suicide may lead them to take his or her life. We're not giving them the idea, right? Instead, we're giving them permission to talk about suicide. Some folks don't talk about it because it feels so, it's the stigma attached to it, and maybe it feels shameful, right? So they don't want to be the one to bring it up. But if we ask them about it, we open the door and let them know that we're comfortable talking about suicide. This one is one that I'll talk about my personal experience. There are talkers and there are doers. Again, especially working in the jail, we had a lot of folks who talked about being suicidal, and we often were very thoughtful about doing a comprehensive assessment to see if there was a secondary gain. You know, do they want to come to health services housing because it feels safer than a dorm? Are they hoping it can impact their court processes, right? A lot of reasons might people say they're suicidal. So we would often talk about the fact people who talk about suicide, like, you know, we don't need to worry about them, right? It's the ones who don't talk about it that we need to worry about. But the reality is, and I love this, VA research, right? People do talk about it. A lot of times they're testing it out. They're curious if someone's going to intervene. They're checking out to see if someone cares. So although it can get tiresome, because I've had so many people talk about suicide and I really wasn't sure which way to go because it felt just like maybe they wanted something else, we take all mentions of suicide seriously. The last thing we want to do is miss something because it's like the boy who cried wolf, right? We assume they just want something else and they're kind of a troublemaker and they're kind of a frequent flyer and they kind of just talk a lot. But the reality is maybe they are just checking in to see if someone cares or someone's going to respond to kind of their cries for help. In fact, years ago now, we had a gal who ended up dying by suicide while she was in jail, which is always so tragic because we know jail is a transitionary place, right? Transitory place. People aren't there long. And oftentimes they don't even know what the rest of their life looks like yet. So the fact that she died in jail was tragic enough, but the aftermath was as tragic because she had talked with 3 of the people that she lived with in the dorm about wanting to kill herself. And we did the follow-up with those 3 gals. All 3 women said we did not think she'd ever actually do it, right? We thought she was just talking about it. So I would say if nothing else from this training today, if you take away the concept of taking people seriously when they say they're suicidal, I'll be happy with that because we want to make sure that we take every comment seriously. We get people who call the crisis line all the time who, oh my gosh, I mean, they're totally inappropriate for me to say, but really kind of are a pain in our ass, right? Like, because they call all the time, they're difficult to talk to, we can do nothing to help them. But some of those are the ones I'm worried about the most because they're calling the hotline all the time. They don't have social support. They don't have other connections. They're calling us to talk, right? So they may be really complicated, but we take them very seriously when they talk about suicide.
Kate, there's a question in the chat from a little while ago on lethal means. It says, can you show the data indicating the amount of people who are struggling with suicide, have access to firearms, and don't attempt or succeed in ending their life? And then part 2 of that is, are you saying that firearms are the only lethal means we need to be cautious of?
Okay, so 2 things to that. I don't have data about the people who have access to firearms and don't attempt. Those are probably like pertinent negatives, right? That's probably data people aren't looking at because they don't have a suicide attempt. So I don't have that data for you. If I find it, I will forward it to Sandy so she can get it to you. The second piece of that is lethal means include a number of things, not just firearms. We talk about firearms a lot because suicide attempts by firearms are so lethal, right? But as I mentioned, people can die by overdosing on medications. Sharp objects in someone's home can be a lethal mean. Nooses, right? So ropes, strings in someone's house. There's anything, there's so many ways people can kill themselves, and anything they use can potentially be a lethal mean. We just talk about firearms the most because of the prevalence of firearms being used in lethal suicides. So hopefully that answers that question, and we can talk about it more at the end if we need to. Thank you for asking those questions. We appreciate it. Next, myth versus reality. If somebody really wants to die by suicide, there's nothing you can do about it. I will also say I believed this when I started in the jail. In fact, I talked with Lieutenant Shepard. Sandy will remember him fondly years ago about maybe we need to change our efforts to suicide reduction rather than suicide prevention. Because if someone really wants to kill themselves in the jail, they're not going to tell us about it. And really, that is false. Over time in my role, I went back to suicide prevention, right? Because there are things we can do to prevent suicide. We can look for signs and symptoms that we talked about, or actually we will talk about signs and symptoms. We can look at protective factors and risk factors. We can practice lethal means safety and help people create safe environments. We can react when they tell us they're having thoughts of suicide. And so if we can intervene, right? Ideally, they're not going to go on to find another method to kill themselves. So a lot of things we can do if we're concerned about someone's suicidality. And so the next portion, we're going to talk about that. What can we do to prevent suicide? And my hope is that a lot of you have attended different kinds of trainings in terms of suicide prevention. I know there's QPR, there's ASSIST, there might be setting-specific suicide prevention trainings that you've attended. This one is really, I hope, because it's only an hour training, right? It's not a 2-hour training, is something that can kind of be layered on top of whatever training you've received and whatever skills you already utilize, because they're so simple. So just so you know, there's not a test at the end. The goal is for this to be, I've used the phrase a couple times here, but truly just another tool in your tool belt. So you have a little more competency and a little more confidence when you're working with someone who you might be concerned about. So the VA SAVE model, which is really the crux of the training that we're doing today, was developed by the VA. But again, it applies not just to veterans, but the general population. And we're going to talk about signs and symptoms of suicidal thinking, how we can ask the most important question of all, how we can validate a person's experience, and then encourage treatment and expedite getting them help. So to make it simple for all of you, really what we're going to focus on here are just 4 points, right? That again, should increase your competency and increase your confidence. We know that working with someone who potentially is suicidal can be really scary. In fact, on our team, and we do suicide prevention all the time, we often use the phrase, don't worry alone. So what I want to do also is stress that although we're doing this training, we know you've had other suicide prevention training, we're giving you some tools in your toolbox. We also hope that you never have to figure this out all by yourself. So whether you have a coworker in an office next to you, if you have an internal messaging system, if you need help by a supervisor or a peer, always reach out, okay? The goal is not that you do this all on your own. The goal is that you have some tools, but you also use your other resources as well. In terms of the signs of suicidal thinking, some of these are going to be obvious ones that we might have thought of before, but one I really want to focus on this slide is that rage or anger. Because typically we tend to react to that by withdrawing from that person. right? And so recognizing that if someone's presenting to us in a period of rage or intense anger, recognizing that that's a sign of distress. If they're super angry, super irate, we know that things aren't going well for them, and they might want us to solve their issue, but really looking behind their presenting problem and recognizing that they're in a lot of distress, I think is really important. It's going to be a little more obvious when we talk with folks who are talking about feeling hopeless. And people in the criminal justice system, right, often feel hopeless, especially when they don't know what the future brings. It is scary to be monitored on probation, right, and not really know what that future looks like. And so that sense of hopelessness of I'm not going to be able to complete this successfully, I'm not going to be able to be successful in prison, right? There's so many components that your folks are dealing with, I imagine. Recognizing them as signs of potential signs of suicidal thinking, I think, is important. And again, this is not a one size fits all. We don't know exactly what makes someone suicidal. Our goal is just to increase your awareness that the folks you are dealing with might be experiencing suicidal thinking. Especially, it's interesting, I think, in the work we do, we almost need to get complacent as a way of self-preservation, right? If we think of everyone we deal with and all their stresses as suicidal, that is so overwhelming. And so finding that middle ground of thinking of those risk factors that we talked about, thinking of those protective factors we were talking about, right? And layering this on top of that and just increasing our awareness, because then potentially we can ask the question and take steps to keep someone safe. The more obvious signs of suicidal thinking, right, are those folks who are talking about killing themselves, looking for ways to die, and also that self-destructive risk-taking behavior. So more obvious signs of suicidal thinking. When we talk about asking the question, this is this piece that seems basic. It can be really hard for people to ask this question. So number one, the reason we do this SAVE training, we want to give everyone permission to ask the question, are you thinking about killing yourself? We want to take away the thought that this needs to be asked by someone who's a clinician or a therapist. In fact, a lot of the people you work with probably don't want to talk to a therapist. We know a lot of our veterans don't want to talk to a therapist, right? You might be the best person to ask this question, especially if you have a decent relationship with the person you're working with, right? So I think the thought that we are not well suited to do this is something I really want to challenge. In fact, you might be the best person to ask this question. A couple things when we talk about that question, if someone is suicidal, there's a couple of do's and don'ts in here, right? We do want to make sure if you're seeing some of those warning signs or symptoms that you ask the question. You might think it's someone else's job to ask the question, kind of like I said on that previous slide, but who else is going to ask it if you don't, right? Maybe this person doesn't present the same way to everybody else. Maybe they're putting on a face for everybody else that they're doing fine. But if you're seeing something that is concerning, we want to make sure that you do ask the question. And ideally, it's part of the conversation, right? We want to make sure that people know that you're comfortable talking about suicide. And as I say that, you may not be totally comfortable. You might have to fake it till you make it a little bit. But we always say, if you don't ask the question and someone goes out and kills themselves, right? Like you can't ask it after the fact. And I know that sounds brutal, but this training really is about increasing our awareness that suicide is real. And we want to take the steps to keep people safe when we can. So when we ask the question, are you thinking of killing yourself? A couple of things come to mind is we want to make sure that we use those words. If we say, are you thinking of hurting yourself? Are you thinking of this or that? We're really beating around the bush, and we might be telling that person that we really don't want to hear what they have to say. If we can't talk about suicide, how are they going to talk about suicide, right? We also want to make it clear that we want to know the answer and that it's important to us. Literally in LA County Jail, I was on a team that did discharge assessments for folks who were in a mental health housing area before they were released to the street. And we had to interview every single one and assess for safety. The way I was trained is you aren't really thinking of killing yourself, right? You want to get released tonight, right? We did not want a yes answer because guess what? Required a lot of paperwork, right? Took a lot of time, and we had a lot of people to see. So we were literally asking people not to tell us if they were suicidal right before they were discharged from jail, which is a huge high risk time. So even though we would suggest that Oh, I would never say that. I've heard clinicians say it. And to bust ourselves out at the VA, I literally heard a front desk person just the other day. Someone was checking in, no one else was around. So they were doing the suicide screening questions. And she said, "You aren't thinking of yourself. You aren't thinking of killing yourself, are you?" So before we say we won't ever phrase things this way, I just want us to pause and go, we might have done that. And let's just think about how we can be better and ask the question in a way that flows with the conversation and also lets people know that we're comfortable hearing the answer. It might require us to slow down. Victoria always talks about the fact that we need to slow down. We need to slow down our own breathing. We need to slow down whatever's going on in our life and make sure we're present with whoever we're talking to. Because if we're going to ask the question, right, because we've recognized signs and symptoms, we thought about risk and protective factors, we're concerned about this person. So we've asked if they're experiencing any suicidal thoughts. We want to make sure that we take the time to validate their experience. So for me, this is another one of those most important slides in this training because it's our intervention, right? So a lot of trainings that we go to with suicide prevention, there's a lot of clinical intervention. There's a lot of things to think about. With the SAVE training, one of the pieces I love about it the most is its simplicity. The intervention for us in the SAVE training is just being with the person, letting them know they're valued, letting them know that you care about what's going on with them, and making sure that they understand that help is available, right? And there's ways we can do that. So I'm going to share my next slide because it talks about this a little bit. Validating the person's experience is really just letting them know that you understand how hard it is. We want to be thoughtful not to minimize. In our culture, we use a lot of phrases like it's really not that bad, it's going to get better. Even saying I've been there may not be validating their experience. So really just sitting with them and hearing them in their distress is the intervention we're using in that SAVE training. So hopefully that feels like it makes sense. We know that it can be less comfortable than it sounds, right? Again, it is scary when someone's experiencing suicidal thoughts, especially if we feel like we can't help them. So what I really want to stress is we're helping them just by hearing them. We've already helped them by asking the question, right? And allowing them to talk about that risk. And just by sitting with them, we're making that connection, which could be life-saving. So let's say we recognize the signs and symptoms, the S, right? We asked the question, the A, we validated their experience. We want to make sure we get them help, right? We want to make sure that we take that information and connect them to resources. So you may have additional training that guides you to provide additional interventions. And so I'll leave that up to you. But for the purpose of our SAVE training, really are talking about identifying someone's concern and then making sure they get connected to help. So that's going to be on the spectrum, right? There's going to be folks who might say, I thought about killing myself, but there's no way I would do that. I've got 3 kids I take care of. I love my dog and I'm connected to my church, right? But we still might be concerned about them. So if that's the case, we want to be encouraging that they get connected to treatment. And again, that could be whatever they're willing to engage in. But if we're concerned that someone is immediately at risk, we do want to make sure that we get help right away. I did talk with someone within the misdemeanor probation system this morning, and I realized my mistake because I worked in Ada County, and I know you all don't work in Ada County. So I apologize because on the slide, what I talked about is if you're working with someone who you think is imminently suicidal, the direction in Ada County that I heard is you contact your ACSO compliance officer for assistance. In your other counties throughout Idaho, do you have something similar to compliance officers on your team? Or is that a different kind of contact that you might have?
Compliance officers are assigned law enforcement officers, like sworn law deputies that assist in Ada County with their probation teams. And so they have law enforcement officers that are assigned to go out in the field with them, things like that. So that's what the compliance officers are.
Yes, but I guess I'm wondering if every county has something similar.
Yeah, so they knew what you're talking about with compliance officers.
Got it. Well, so 2 things then, just in the interest of time, I will say is, if you have within your own guidelines and policies, I always want to make sure you follow your internal training and your internal policy first, That's going to be most important, right? I know some counties have crisis intervention teams, and they're a great resource if we're concerned about someone's immediate risk. But your other options include, if we really think someone's at immediate risk, right? Even calling 911, if we're concerned about transporting someone to an emergency department or to an urgent care, never hesitate to call for immediate help if that's appropriate. And again, with this slide, it really is about knowing what your internal processes are. So what I encourage you to do is, if you're not sure what that looks like, talk to your supervisor, right? Find out exactly what you're supposed to do when someone is at risk and they're sitting in front of you. Because hopefully this training will prompt you to really learn exactly what your response should look like. So again, this slide really is about encouraging treatment and expediting getting help in a manner that's consistent with your own guidelines and policies. If you're not sure what to do, talk with a supervisor, talk with a peer, 911 if it's an emergency. And then we always talk about those crisis lines and hotlines, both the Idaho Crisis and Suicide Hotline at 988 and the Veterans Crisis Line at 988 Press 1 are great options for folks who maybe are not at immediate risk, but can really use some help on an ongoing basis as well. 988, as you may or may not know, also has a newly oriented their own mobile crisis team that are available to technically respond statewide. So that's an option as well. Checking time, taking a sip of water, and really quick, any questions on anything else I just talked about? Because we talked about kind of that crux, right? The tools of that SAVE training. Any questions on signs and symptoms, asking the question, validating someone's experience, and encouraging or expediting care? And again, that's really just an excuse for me to drink water. So, but if you have a question, I do want to hear it. Also want to drink water. Both are true. Okay. So what we want to talk about here is help us again with our competency and our feeling of confidence when we're working with someone who's suicidal. I know, again, I've said it a million times, I talk fast, I tend to work fast, I tend to move fast, less fast the older I get, but still. My heart rate goes up when I'm talking with someone who's suicidal still, because our folks, we call people who call the Veterans Crisis Line, we call them back. We talk with people in crisis all the time. I still feel my physiology, is that the word? Physiology, kind of quicken, right? I feel my blood pressure go up. I feel everything, my heart pumping, and I actively have to calm myself down. So I would suggest if that happens to me, I know it happens to people on our team, it happens to a lot of folks. And again, regardless of how long you've been doing this, regardless of how many people you've talked to who've been at risk, because everyone is unique and there's so many unknown factors. So first thing we really, really want to do is make sure we're breathing. Make sure, and it says remain calm, right? That's why I'm talking through the details. Easier said than done. Sometimes that check in on your body, like, are you feeling tense? Doing a little progressive muscle relaxation, literally tensing muscles and relaxing them. Doing some deep breathing, kind of ground yourself, right? Remind yourself you're already helping them because you're already validating their experience. You're already going to connect them to care. The hardest piece for me is listening more than you speak. We are fixers in this world. We want to fix things. But in this case, we really just want to validate their experience. And nothing is more validating than someone listening to you, right? If we think about that, who in our lives really listen to us, like really get us, really listen? That's our goal, because there's no perfect thing we're going to say. We want to allow them to talk. They're the person that's experiencing the crisis. We want to allow them the honor of hearing their story, right? We're creating that connectedness. This is a place, I know it's kind of, we're not arguing. This isn't a place for us to insert our opinion. We are literally taking on their stressor and validating their experience. We do want to make sure if we're in person with them that they know we're there for them, right? If we're sitting back and crossing our arms, we all know by now what message that sends. So we also want to have that nonverbal to show them that we care. We're leaning in, we're paying attention. We also, I love that last slide. We want to make sure the last line, we want to make sure there's no quick solutions, but that help is available. We never want to make promises that we can't keep. We always want to be careful about that. Again, because we're fixers, we want to come up with solutions. Let's just make sure we're not promising things that don't make sense. Just a little slide. And again, this is going to be depending on what happens in your area. But if someone is on a call and you're on a phone with someone who's expressing suicidal ideation, just a couple of tips. We want to try to keep them on the line and get their identifying information, get where they are. Because if they hang up and you need to send out someone for a welfare check, we want to know where they are. So those are really the top tips on that slide. Early on, ask where people are if we're concerned that they're in crisis. And then you want to get help, right? What is the guideline and the policy for your specific setting to make sure that you're following that appropriately? And again, I apologize if compliance officer CIT doesn't fit your setting. Know what your setting specific direction looks like. Suicide is preventable. Suicide prevention is everyone's responsibility. And if nothing else, remember that you may be the best person to talk with the person in front of you about suicide. It may not be a clinician, may not be someone else. You may be in that unique position to have that conversation with someone. So hopefully this information helps to increase your comfort level with that just a little bit. A couple of resources. If they're not a veteran, calling 988, that crisis line is also such a great resource, especially at 3 in the morning. If they're a veteran, pressing 1 to access the Veterans Crisis Line is a great resource. More information on firearm safety. You can go to keepitsecure.net, learn more about firearm safety. Also the National Shooting Sports Foundation, www.nssf.org. More this is veteran specific, but really it applies to the whole general population. We have a lot of brochures on lethal means safety. So if you need anything, let Sandy know. We'll make sure you get it. We left a little bit of time for questions. And I did want to check also if Tacey may not have been able to join our call. Let me ask first. Tacey McCoy, have you been able to join us? Okay, I don't see her. I'm going to do a quick shout out for if you're working with veterans who experience a suicidal crisis. There's been new legislation passed with the intent to take away cost as a barrier to care. So if there is an eligible veteran, and the eligibility criteria is actually pretty easy, they have to serve around, I want to say at least 24 months. They don't have to be connected to the VA, and there's some other eligibility criteria as well. But if they meet that criteria, they can go to the ER free of charge. They're also eligible for up to 30 days of inpatient care free of charge and up to 90 days of outpatient care free of charge. We've heard too many people talk about being suicidal but not wanting to go to the ER because it's too expensive. Compact Act takes away that cost as a barrier. So if you're working with a veteran and they're in a suicidal crisis, please know that they won't be charged for that ER visit, for the resulting inpatient care if that's indicated, and the outpatient care. Again, there's some brief eligibility information, and I can actually send that out to everybody as well if you're interested, so you have that. So little shout out for Compact Act stuff. And I left a little bit of time at the end for questions. So again, no, I talk fast, a lot of information, especially on suicide. So if there's questions or if anyone on my team has anything that they want to add that I didn't talk about, please feel free to speak up while I drink more water.
Kate, while you're drinking water, there is one question in the chat about whether or not you have suicide rate data specific to probationers.
Oh, I don't. I will look it up though. I'll see if I can find it. Victoria, who's on this call, is a fabulous researcher. She's been a professor at BSU, super, super smart. So I'm going to ask Victoria if we can look that up, and I will get back to you. But I apologize, I don't have that on this call. And the last thing I want to do is even speculate on that.
And Victoria, thank you for sharing the compact brochure in the chat.
Oh,
She just put that there. That's helpful. So if you need it, grab it out of the chat, please.
that's awesome. And if there's no questions, we are happy to conclude the training, but I always know there's oftentimes someone who's hesitant to speak up. What I will say is if you have a question, someone else probably has the same question. I know we haven't had answers to some of the questions, but we will always try to get you information and send it out after the training as well, if that's helpful.
Looks like we are good. I I got an extra screen, so just want to make sure there's nothing in the chat, which there isn't. So thank you again, everybody, for coming. Thank you so much to Kate and for the others who joined from the VA. It's always nice when you have a friend who will do favors for you for free. And so I
Wait,
appreciate
this is
that,
for
Kate.
free?
Oh, it's totally free. Yeah, thank you.
Just kidding.
All right. We will, if anybody needs any additional resources, please reach out, let me know, and I will connect with Kate and the team at the VA and make sure we get them to you. Anything that was mentioned today. Again, just a reminder, if you signed a post roster, send them my way. Hopefully you all have my email address just in case. I will put that in the chat really quick.
And did you see Victoria, who is friggin' awesome, already put in a meta-analysis on the topic of probationers and suicide risk? That's how awesome she is.
Fantastic. There you go.
Well, thank you all for your time and attention. I know it's a tough topic. And again, hopefully you just took away one nugget. If you have one more tool for your toolbox, it's worth it. So I hope you got that today. And again, thank you for just tuning in. We appreciate it.
Thanks, everyone. See you next time.
Thank you.
Thank you, Kate. Much appreciated.
You're welcome. I hope you have a great day.
Yeah, you too. Think that went well. Everybody, I think we still have some people on, but oh, I can stop recording. Stop.